Hi, very good afternoon. So I think some of the place, especially in Greece, all is good morning there. Thank you for joining us. So I'm Dr. Glendon. I'm from Malaysia Hospital Sultan Idris Shah Sedang. So today we are very fortunate to have to join us another three distinguished speaker, prominent cardiologists from Greece, from UAE, and also from Malaysia. So I will introduce the speaker one by one. So first, we have Dr. Faizal. He's actually my very close colleague who is working together in Hospital Sultan Idris Shah. And he's a consultant cardiologist, intervention cardiologist, and also trained in endovascular. Then we have Dr. Naveed. Dr. Naveed Ahmed is a consultant interventional cardiologist and head of Department of Cardiology Center at Esther Hospital, Dubai. And he did his fellowship in interventional cardiologist and also structural heart intervention in Toronto. And also, finally, is Dr. Ioannis. I think he's a director in First Cardiology Department with Cross Hospital, Athens. All right. So, thank you very much for joining us today. So, I think today we'll start off with the first case presentation, right? Which will be presented by Dr. Faizal. We without further ado, I'll just invite Dr. Faizal.
Thank you, Dr. Glendon. Can you hear me?
Yeah, I can hear you.
Okay, so I'll be sharing my screen. Okay, yes. Thank you, Dr. Glendon, for the kind introduction. Good afternoon and good morning in some areas. I'm Dr. Faizal. I'm working in Malaysia in Hospital Sedang. So I'll be starting off with one of my case that a wedge NC has been used has been uh, uh, very important during our procedure. So going to the case, this is a 55-year-old man. Is an ex-smoker. He's a diabetes mellitus, hypertension, dyslipidemia. He had a history of non-ST elevation MI in 2015. PCR to LED was done. Circumflex was labeled as moderate and RC was recessive. And this time, this year was just done a few weeks back. This time he had a history of admission for unstable angina. And his ECG has remained sinus rhythm. And echo has been normal. There's no any wall motion abnormalities. So we proceeded with the coronary angiogram for this patient. So from the spider view, you can see there is a tight lesion at the mid LAD here. And there is from the angiogram itself, you can already see there are a significant calcification from the proximal to the middle mid LAD. And this is for cranial view, diffuse instability stenosis, ranging from 7 to 90%. And there's also a distal LAD, very tight, 99% stenosis. And from the caudal view, you can see the osteate LAD also is diseased, at least 50%, followed by diffuse ISR. Circumflex, distal circumflex, I'll say just a moderate disease. And RCA was recessive. So we are looking into in a patient who has a very dominant lab system with ISR of LAD and diffuse ISR LAD and at least a moderate calcification from the angiogram itself. So we at the moment the modification of calcium has been questioned. What are the mode of modification of calcium? So I decided to assess it by IVUS. So we proceed with the PCR LED. Guiding catheter was used was EBU30, wire serum blue to LED. I just pre-dilated the distal LED with 1.5 balloon, not to cause a major dissection, just to get IVUS in. So this is the IVUS finding. So the distal reference lumen of the distal LAD was 2.5 mm, and this is the size of the lumen 1.5 mm MLA after the pre-dilatation with the 1.5 balloon. And if you can see here, the reference lumen for the LAD, mid LAD was at least 3.75 mm. And the tightest region here is it has around 74 to 25% plug burden, MLA of 3.68. The proximal LAD, if you can see here, it is almost 360-degree classification. And also this is almost ostial LAD, only 4.47 millimeter squared of MLA. And this area there's a short segment which has not stented. So this is reference lumen, the reference size for the distal LAD, and this reference size at the distal or the mid LAD. So now we can see the calcium. 360 degrees calciums are there, 270 degrees calciums ranging from more than 5 mm are there. So based on calcium score on IVUS, there are calcium score more than 270 degrees in 5 mm. There is a two segments of 360 degree calcium, which are seen by this picture that we saw earlier. And I thought I saw a nodule there. I thought that was a nodule, and I put as another yes. Vessel diameter at least is more than 3.5, so it's a no there. So we have at least 2 to 3 calcium score in this based on IVUS score. And we all know the standard expression will percentage reduce less than 80% as the calcium score becoming more than 2 or 3. So obviously there are a few methods that we know. It's either you use a rotation atherectomy or other mode atherectomy like orbital. And I personally feel in this case, IVL will be a better choice because we have a large lumen size, 3.5 and 4.0 lumen of the proximal. And this is something that I want to consider. And of course, we also have a lot of other options of calcium modifying balloons, like a Scoreflex, Angioscope, Wolverine, NEC Alpha, and of course, Wedge balloon, which is the new upgraded was which is Wedge NC scoring a balloon. And we know that there's advantages of the Wedge NC. It has a robust and precision scoring balloon. It's an ideal for instant stenosis, as in our case. It's a specialty for hard calcified lesion, precise control and minimal doggy bone and slippage, and it's also suitable for bifurcation. And this is something that I considered for this case before I jump into the IVL. So what I did was I wanted to try using a smaller balloon, which was a 3.0 Wedge NC. I pre-dilated the lesions from the distal to proximal, the ISR lesions. And I want to see how success was my calcium modifying by just using 3.0 NC before I go into the bigger balloons. This will give me benefit of looking at the of my success rate of calcium modifying by using a wedge. At the same time, not to over expand or causing a dissection and making rest of my if I want to upgrade to atherectomy or IVL, be much more difficult when there's severe dissections. So this was the proximal LAD. You can see some dot boning there. Of course, that is 3.0 balloon. I don't expect it to expand so much. So this is the IVUS assessed after the 3.0 NC wedge. I do see a lot of break in the calcium, a lot of discontinuities there. As you can see, this was not seen earlier. There's some cracks here, there's some cracks there. You can see there's reverberations seen. And you can see much more discontinuity in the proximal LAD. And this is a 360-degree calcium. You can see some cracks here. You can see reverberations coming in. And this is also seen here. This is very much, you can appreciate how much the even 3O wedge has cracked our calcium. So this give me more confidence in taking a bigger balloons, and I was quite confident that bigger balloons can modify even better. So this time I took a 3.5 NC wedge, and you can see the drop ballooning seen here. And as I pull back, going a higher pressure, it opens up the calcium. And this is going to also 3.5 NC at the proximate lady. And this is 3.5 NC high pressure at the proximate lady. And this is after 3.5 wedge. So I was quite happy with the result. So this time I took a 4.0 NC. This is a normal NC balloon to go higher pressure. And I noticed there are slip. So when I want to exactly place my balloon at the near stand, when the balloon dilated, I can see it slip forward, and also there are minimal drop ballooning seen here. So this time I took another 4.0 score again, and what was seen, the drop ballooning here was not seen here. So this proved that drop ballooning effect and also the slippage of the balloon is much more better treated with the scoring balloon, like in the Wedge NC. So I was quite happy with the expansion of the balloon, and I end up pre-dilated further, prepared the distillery further with 2.5 NC, and treated it with the drug-coated balloon. I used to restore 2.520, and I treated the whole ISR with the DCB 3.530, and treated the proximal segment with the DCB restore 4.0, and I stented. There are very small segment of proximal lady which wasn't stented. I used a short stent, drag extrusion stent of 4.015, and this was the result. And I post-dilated 4.0 NC, high pressure from the mid to the proximate lady. And this was my final result. And I was quite happy with the result. And IVUS, so this is the IVUS. You can see the MLA has much improved of the proximal lady, and if you look at the segment by segment, this is the distal lady, the DCB area, the MLA improved to 2.87, but this is not particularly important in the DCB area. And this is comparison with the distal segment. The MLA changes has improved to 5, and the mid LED, the MLA has improved to 7.48, and proximal LED it has improved to 9.6 from the earlier. So this is as comparison before and after the result. So in conclusion, scoring balloon could be an alternative for main calcium modifying strategy. In this case, though IVUS calcium score shows better outcomes seen by using calcium modifying devices such as tetramethy or IVL, obviously scoring balloon has proved to be much more efficacy in achieving good luminal gain. Of course, I have used imaging to guide my success of calcium modification by ballooning. So I looked into the reverberation, I looked into the calcium cracks before I proceed with the bigger balloon to avoid severe dissections with improper calcium modification. And of course, even in a 360 degrees calcium, Wedge NC has proven to show benefit. Scoring balloon also proved to be more successful in achieving better luminal gain of the ballooning, as we saw in two different segments. And it's also helped in a balloon slipping issues that what I faced here. With that, thank you.
Thank you, Faizal, for that case. A very good result. But it's just that with the IVERS finding, I think probably some of us would have just opted for IVL upfront. So um, I mean, looking at this, how do you actually differentiate, or how do you think that this might work? How do you, I mean, case to case basis, lah, what make you think that this would have I mean, the scoring balloon would have worked well for this case, huh?
Okay, so if IBL was my first choice, however, I know patient will need at least 2 IBL. That means 3.5 for the distal part and a possibility of 4.0. Of course, cost will be an issue. It is a very expensive device. So for me, I guide my IVERS finding after the initial balloon. The moment I saw multiple cracks, reverberation seen after the initial balloon, and I was quite confident my bigger balloons will have a better effect. So that's why I go with the. I didn't go all the way to 4. I got 3.0 and 3.5, and at each part of my procedure, I look at the expansion of the balloon. I did not see any major dot ballooning, in a balloon, and that's why I was going much higher with a 4.0, and I did not see much wasting, and end up I managed to successfully complete the procedure without using IVL, which is not. Of course, IVL will definitely be a much more. It is a you don't really need to confirm it with the cracks and everything, because you would definitely have a cracks with the IVL. But we need 2 IVL. That's why I can manage it without just using a Wedge NC balloon here.
Okay, sure. Because I mean, I think in our country, in our region, Malaysia, IVL is very costly, lah. So if to use two, then it will be a bit problem. Maybe we can hear from our colleague from, I mean, probably Dr. Ioannis. I mean, what is your um opinion about, or any comment of this case?
Can you hear me now?
Yeah, sure.
Good morning from
Hi.
Athens,
Yeah,
Greece. Thank you for the invitation. It's a great pleasure being with you. I saw a fantastic presentation from a colleague. Very nice presentation of demonstration the use of a scoring balloon and how it looks with the use of IVOS. I'm not that familiar with. I have no so much financial points to use IVOS in every calcified case, because I do many cases here, complex cases. So I usually use IVOS for left main, or where there's doubt about the result. So I had this was a fantastic demonstration of how it works with the IVOS, and I was amazed for these pictures, and I think it was very didactic for us.
Okay. So what about Dr. Naveed?
Hi. It was a wonderful demonstration to show how Wedge helped in this case. So thank you. Congratulations for the wonderful case and nice demonstration. I felt like the approach was excellent. And again, in terms of IVL, I'm not very comfortable, especially there's no indication, a strong indication of IVL in ISR. Because we don't know what is the impact of IVL on the stent. Especially, there are a lot of cases where people have done IVL in ISR, and that might result in stent fracture as well. Because all of us know IVL is a pulsed ultrasound, which is equivalent to 50 atmosphere kind of pressure. So it is hitting the hammer, kind of. So I had one case of proximal RCA where it was an ISR. Again, a calcium, the under expansion of the stents again to calcium. So I used IVL, And ultimately, I did DCB without realizing he had stent fracture after that. Then the patient came back. I had to put one more stent. So I think the approach was good. If the purpose is to make sure the stent has expanded and there is no ring of calcium, and nicely demonstrated how we could see the reverberation, which shows he had fractured the calcium, and finally stent expanded and the area gain was excellent. I think this would give a long-term result. So without compromising or resulting in stent fracture. So I think that is an ideal approach all of us should have.
Okay. All right. Thank you. So I think it's good case from Dr. Faizal. Probably we'll just move on to the second case that is by Dr. Naveed yourself to be with the topic of what's the topic right to control dissection as a treatment strategy. So over to you, Dr. Naveed.
Thank you so much. So when when we talk about iatrogenic dissection, we are scared. We normally think of complication related to catheter or balloon, and that scares us. But in this era where we have a scoring balloon, cutting balloon, there's a concept of controlled dissection which can be used as a treatment strategy rather than considering it as a complication. Since non-compliant balloons, sometimes when we go semi-compliant or non-compliant, when we pre-direct lesions, especially at high pressure, the dissection, rather than getting having a focal dissection at the lesion spot, we have seen, I think all of us have experienced, the dissection goes well beyond the disease area, either proximally or distally. We end up either putting multiple stents or very long stent, which again has a poor long-term results. That's where the strategy of controlled dissection has come up. So just briefly introduction, this scoring balloon represents a mechanistic evolution of cutting balloon with the attempt of reducing mechanical trauma exerted in the vessel wall with focused force inflation while making it more deliverable than its predecessor. By scoring the arterial lumen, the risk of coronary artery dissection is reduced, but the degree of luminal expansion is preserved when compared with the traditional cutting balloon. And observational OCT study suggested the use of scoring balloon led to successfully modification up to 68% of the lesion with no comparator arm with non-compliant balloon in the study. So another randomized study compared three strategies: direct stenting without pre-dilatation, conventional semi-compliant balloon dilatation, and pre-dilatation with a scoring balloon. And IVAS data confirmed minimal stent area was greater with the scoring balloon compared to the other two strategy with a good long term. And another prepare cal trial showed 9 months there was no difference in mean instant late lumen loss with cutting or scoring balloon compared to rotational atherectomy. With this, I'll be presenting some cases with different strategies showing how scoring balloon helps us to optimize the results. So this gentleman, 64 years old, is diabetic and hypertensive, admitted with non-STEMI with adequate LV function. Angiogram showed 100% occluded ramus, severe disease in OM1 and PLV. So the first image shows it's a large PLV disease right from the ostia till the mid segment. The PDA looks fine. And in the second image, if you see, the ramus is occluded and this disease OM1 ostial disease. So the plan was to do PTCA to PLV, ramus, and LCX to OM1 stent. So initially, since the lesion involved the ostial occlusion of ramus, the plan was not to put a stent. The plan was to open up the block, crack it, and DCB if possible. That was the ultimate aim with this person. So with the intention of DCB, I didn't want to go very high pressure with back dissection. So I thought it's better to take scoring balloon. So we took 2.25 into 10 wedge scoring balloon, which we went up to 10 to 18 atmosphere. Here, it was not one inflation, multiple inflation. So what normally I do is I inflate at one angle and then I rotate it out 90 to 180 degree so that we can score at different levels. So that will give a better scoring of the lesion and which will help in better expansion of when we predilate with the subsequent regular balloon or non-compliant balloon. So this was the scoring balloon. And when I started this, initially it It started dog boning, but ultimately it started melon seeding. Ultimately, I could break the lesion, and at multiple angles, so to 180 degree, 200, 260 degree, we rotated, and we could crack it at multiple places. Finally, this was the after scoring balloon inflation, and this was followed by DCB. 2.25 into 25 dCV at 6 atmosphere 120. There's no waste. The balloon is uniformly expanded, and this was the final result. It shows like stent-like result. So we ended up only with DCB, and then finally we also stented LCXOM, and this is the good final result of REMUS. Then subsequently we started treating the PLV. The PLV initially could not be crossed with the directly with the scoring balloon, so I had to take 1.5 into 10 regular balloon, non-compliant, which to open up and create some way for scoring balloon. Then we took the scoring balloon, inflated at 12 to 18 atmosphere in a similar strategy at multiple angles, rotating it. Then finally, after pre-dilatation, the balloon angioplasty result was good. This was followed by 2.5 to 30 dCB, again 6 atmosphere for 2 minutes. And this was the final result after DCB. So no, it's like a controlled dissection with non-flow limiting dissection with almost stent-like result with minimal or no recoil of the vessel. So the second case is 43-year-old diabetic hyperdyslipidemia admitted again with non-ST elevation MI. Angiogram showed subtotal occlusion of distal LCXOM with severe disease in diag. So plan was to put a stent to OM and then the DCB to diag. So if you see diag has proximal diag has a high grade lesion. So again pre-dilated with 2.5 into 15 wedge scoring balloon. And there's minimal or no waste. And this is after pre-dilatation. The result looks good. It's like less than, see, when we plan for DCB, even the guidelines say the recoil or this thing should be less than 30%. So this was a DCB inflated. And this is the final result with no visible dissection with good flow. Then the next strategy is a stent strategy where we can use the scoring balloon. So this is a 50-year-old gentleman, hypertension, admitted again with non-ST elevation MI. He presented with ongoing chest pain. He had moderate LV dysfunction, and angiogram showed subtotal occlusion of mid-LAD. So non-dominant RCA, and if you see the mid-LAD is calcified, and it's a high-grade lesion. And lesion extends from proximal till the mid-LAD across the diag, but tightest spot being at the mid-level after diag. So the lesion was quite calcified. So that was the reason we started with scoring balloon, hoping like it will help us to crack the calcium and help in opening up the stent in an adequate manner. So 2.5 15 wedge balloon went at high pressure, 20 atmosphere, again multiple inflation at different angles. So we can see the calcium. And this is after pre-dilatation. We got just the dissection at the spot. And this was followed by 3 into 40 drug-eluting stent deployed. And then pot done with 3.5 and then post-dilatation with 3 non-compliant balloon. And this is the final result, which shows complete expansion of the stent. So the last case is 68-year-old diabetic hypertensive. Is a status post PTC in 2016. Again, admitted with the non-ST elevation MI. He had adequate LV function. So angiogram showed good LAD stent. No other significant disease on the left system. He had osteoproximal RCA disease. So it was significantly tight disease. So initially, pre-dilatation was done with the regular non-compliant 315 non-compliant balloon, very high pressure. Somehow still we can see there's a waste. It did not heal. So there was a recoil. And then we took 315 wedge, went at 20 atmosphere. The waste disappeared. And this was followed by stent. osteal positioning deployed, and then 410 non-compliant balloon at very high pressure, and this is the final result. So this case demonstrates how the regular non-compliant balloon, despite of high pressure, did not yield the lesion, but with the scoring balloon, I could crack the lesion, and that helped in good expansion of the stent. So these were the series of cases to demonstrate how how we can control the dissection and crack the lesion for complete expansion of the stent. So yeah, that's it. Thank you.
So thank you, Dr. Naveed. Very nicely shown cases of using scoring balloon. I'm very interested with your first two cases where you actually DCB it now, because in our center also we are using more and more DCB. So to what extent of the dissection will you actually accept deploying a DCB?
Yeah. So I normally see for if there is any staining, flow limiting dissection, I stop. Or if there is any significant recoil, I stop. I go for regulating stent in that case.
Yeah.
Any staining.
Your second case was very nice. The result, you a bit of recoil, you put in a DCB, the diagonal was excellent result towards the end. So one more question is, if you you deploy a lot of DCB, do you actually bring the patient back to relook or not the lesion? Those with like type A, B dissection that will you actually bring them back and just have a look at what happened after 3 months?
So since we know the practice doesn't allow, even the ethics does not allow us to do recath without any indication. There are some of the cases who follow up with me, who present with atypical or sometimes TMT positive, the same patient which I have done 6 months or a year before DCB. I have done a couple of cases, I've done angio, and surprisingly, so far, most of the arteries have remained patent with complete healing of the dissection, what was done earlier. So routinely, yeah, the practice I cannot do it because the guideline do not indicate, and also since this is an insurance-based practice here, I cannot get approval for like without indication. I cannot request insurance to approve for an angiogram, and some of the cases which get approved, what I have seen is the results have been excellent so far.
The reason I'm saying is because what we normally, there are few cases where we DCB and they had multiple lesions. So we only managed to do the left side. So we brought the patient to stitch the right side. So at the same time, we took the opportunity to look at what happened to the left side that we did. So as what you mentioned, I think most of them came back with very good positive remodeling result.
Yeah.
All right. So
similar
excellent cases. Sorry.
Yeah, thank you. No, similar way, that's what I'm saying. For any other reason, if we catch them or stage them for a different vessel, when we relook, so far the results have been good. And I think the concept of DCB is coming up more and more, even in acute coronary syndrome, even in STEMI. There are plenty of trials going on, even not only for the small vessel now, for proximal vessels, the data is building up more and more. I think that's where the role of these modified balloons will come up. I think the future, more than this regular non-compliant balloon, I think either the scoring or cutting balloon will take an edge, where especially for the focal lesions where we don't want to put stent even in bigger arteries, we can just use this scoring or cutting balloon, just dissect at that point, a non-flow limiting dissection, and probably do DCB and come out. I think the future for this scoring and cutting balloon is quite high.
Yeah. So I totally agree. So we can conclude here that if we plan upfront to DCB a lesion, to start off with a scoring balloon will be a better option, right?
Right. That will be the take-home message from my side.
Yeah. Any comment from Dr. Ioannis?
Yes. Congrats, Dr. Naveed. It was fantastic demonstration. It was he demonstrated that philosophy of doing small minimal dissection and giving the liver drug there because it's been absorbed better when there is a minimal dissection. So this is the point. And I think it was very nice. It's a fantastic idea, and I'm sure in the future it's gonna get more and more ground in our cases. So I think you showed it very well, and I think maybe there was a balloon, a scoring balloon with dragon on it in the past. I don't know if it's in the market these days, because I've used some cases some years ago. There was a scoring balloon that was coated with drag in the past. I don't know if it exists till now, and this is the idea that it was made. So I think it was a very nice demonstration, and congrats for it.
Thank you.
It's a great case. I think you demonstrated, especially the last two cases where the calcium dot booning was treated with the wedge. As you even saw in my case, dot booning was actually much lesser in a scoring balloon. In fact, my center, we use a lot of rotation atherectomy, and our threshold is very low. And of course, using this newer scoring balloon, especially Wedge NC, it has in fact opened up my practice into looking into this dot booning, where a scoring balloon will be much more better device to treat these particular issues. It was a fantastic case, and of course, you have showed using a scoring in TCB cases, minimize the stent use in this kind of cases was well done.
Thank you.
So okay, I think we will move on to the next case by Dr. Ioannis. I'm going to talk about my scoring partner Wedge NC to achieve more in complex lesion.
Hi again, very nice point here, very nice meeting, and I'm going to show you how I use it in daily practice, because our daily practice here is many complex cases, three vessel disease and calcium and CTOs. So this is going to be our cases to show. This is the first case, the male patient, 60 years old, with peripheral arterial problem, and he had cardiovascular risk factors, hypertension, dyslipidemia, and ex-smoker. And he presented with a non-ST elevation MI with ejection fraction 45%, and he suffered from angina last days before his admission to our hospital. And this is his coronary angiogram. As you can see, it's a three-vessel disease with a tight lesion LAD after the first diagram, and classified the RCA, and really disease the RCA with aggregation classifications totally apart, and really tough answer. So why do we deal with these cases? Because we know that we have to achieve complete revascularization in our cath lab. And we know that if we don't succeed complete revascularization, we do not have better outcomes for our patients. So from Syntax trial, we know that remaining Syntax score over 8, it predicts worse outcomes at 4 and 5 years. And this is from New York State reporting system, and it says as well that complete revascularization is better for our patients. The same data came from UK Central database. So when we succeed complete revasc, our patients go better in hard points at 4 and 5 years. And this comes again from New York cardiac registry. You see that comparing PCI with coronary artery bypass grafting, we have overall musculoskeletal stent and bypass grafting at 4 years. We had more MIs in the branch of patients that went with PCI. But if we see better these patients, the difference was coming from incomplete revascularization. So complete revasc is the point that we have to achieve in our cath labs. So when we have to have a complete revasc, we have to deal with all these cases. That's why we cannot avoid calcium, we cannot avoid CTOs, we cannot avoid all these difficult lesions. So the first procedure was to deal with right coronary artery, radial axis, with 6 French AL1 catheter. Can you hear me? It's okay? Can you hear me? Is it okay?
We can hear you.
Okay. So, we started, we had a wire distal whisper MS, but then the lesion proved uncrossable first. According to our algorithm, first of all, we had to use a small profile balloon to inflate for predilatation as long as we could, and alveolar HP 1.0 was used and was burst. After that, main inflation, but we could not move distally. It seemed really difficult to go distally. Then we tried to deliver the pike spiral microcatheter and maybe exchange to a rotor wire and do rotablation in the mid part, but didn't go distally or even deliver a rotor wire before passing the lesion. We were unable to deliver a rotor wire distally. Again, smaller profile balloon, alveo 0.75 was used, and maybe did a little modification in the proximal part of the lesion. And then third pike could go a little bit distally, and the rotor wire was delivered in the distal part of the vessel. First was in a branch, but we did rotablation with the rotor wire in the branch. So rotabur 1.25 was used and could not pass first, and after that we increased the rate to 190 and was past the lesion after all. And then we tried to balloon with NC balloons, but we were not happy with that. Couldn't expand the good shape. So after that, according to the algorithm, we had to use a scoring balloon. This is the algorithm from Manos and Cabis, and this is how comes the scoring balloon in this algorithm. We have all these options we all know: intravascular lithotripsy, OPN balloons, and laser atherectomy, angioplasty, and everything else. But we have to take first this option and to use these balloons. And this is from Manos about CTO. Again, answer sculptor cutting balloon is high in the algorithm. In that case, you use the Wedge NC balloon. So it is suitable for in-stent stenosis, for calcified lesions, and for bifurcation, and reduces, as we said before, dog boning effect, and creates, as we had this fine demonstration, a very controlled dissection in our vessel. And these are the sizes of these balloons. So a wedge balloon, 2.5, 15 scoring balloon was used and was applied in the whole vessel with very good expansion. And after that, we could use multiple balloons and see bigger size, and the inflation was fine. And we could end the vessel. I would change view. We saw an extravasation in the distal part, and we put graft stand there and close the branch, and no problem with the patient. No procedure in the same patient, we had to deal with LAD. It was not that difficult. But after putting the stand, the was closed and the patient suffered pain. We managed to put a wire in the diagonal, and with a small profile balloon HP, we did the inflation there, and everything was fine with fine flow in the LAD and the diagonal branch. The third procedure was about LTX. We knew about the calcium of this patient in the previous attempt in RCA. We used the Wedge NC 275/20 for pre-dilatation with a fine result. And then we put 2 stents post-dilated with a fine result. So in this patient, we achieved complete revascularization in 3 procedures, very calcified lesions with help from scoring balloon, fantastic result for our patients. And for bonus, there was a last eve case. There was a patient that we did some weeks ago LCX CTO successfully, and there was this difficult spot calcified lesion in LAT. We did pre-dilatation. We passed with a wire in the distal part, and we did pre-dilatation preparation with a Wedge NC balloon 2.0. And after that, NC balloons dilated in a good way. And we had the final result with a good deposition, as we see here in the stent boost. So the key learning points from our cases is that complete revascularization has major importance for our patients and to achieve the outcomes, better outcomes for our patients. In order to achieve complete revascularization in our cath lab, we have to deal with complex PCIs. There's no other way. Calcium and total occlusions are nevertheless the main problem of achieving complete revascularization. So undilatable CTO and non-CTO lesion is not an uncommon problem. All the weapons should be available in our cath lab. Scoring balloons come early in the algorithm from dilatable lesion and can replace cutting balloons. May give the solution instead of more expensive tools as lithotripsy. Post-dilatation as well may be successful with this kind of balloons. And this specific balloon, Wedge NC balloon, is a fine option with a profile capable to achieve the best outcomes that we want for our patients. Thank you very much.
Thank you, Dr. Ioannis. Very complex cases. The first case, I'm just a question. You did all three vessels in the same setting, is it? For the first case, the one that you wrote up. I mean, after your RCA, you went to your LAD and your CERT, the same setting.
No, it was not in the same. It was 3 procedures. It was
Okay.
three different
Okay.
procedures.
So, oh, all right. Okay. So I mean, the first case just shows that even after modifying the calcium with rota, you still need a NC scoring balloon to actually prepare the lesion properly. So very nice result. I mean, even with the CTO second case, very excellent result with the NC scoring. Anything from Dr. Naveed? I mean, anything to add on?
No, it was
A
indeed
comment.
very
I think just a comment. I think it was it was when you use rod ablation, it's very expensive after that to use as well IVL. So I think this is a point for colleagues to know that they have this opportunity to have this possibility to to load the to load the damage, the financial problems, and this is a way after ablation you can use these balloons as well.
I agreed, Dr. Ioannis. Yeah, nice demonstration. Rightly told, like rota shock is like what a lot of people have presented, where they do atherectomy and then shock wave. It looks very easy, and it's easy, but again, it comes with a bigger cost. So when we are working in the industry where reimbursement is a bigger issue, we have to find some solution which is as effective and as well as safe to the patient, and which will give long term. I think that should be what we look for, and nicely demonstrated by your case where you did rota and then probably others would have used shockwave, but because anyhow we need to crack it. Once a rota is done, it just modulates the calcium. It doesn't shave off it. It modifies the plaque, and then we need something to crack it finally. So I think using this scoring balloon, which will help in cracking the lesion and then the expansion of the stent, was nicely demonstrated by you. So
May I know, Dr.
Thank you.
Ioannis, what burr you used for the rota?
What's the size of the burr?
I used it was 125.
125 or
I went
75?
I
3.25.
had many rates. I went to 190 190.
Do you think you want to go for bigger burr, because I
Yeah,
think
if you could pass,
large vessel.
Yeah, if you couldn't pass, I would use because it was really tight. It was uncrossable. So I first started. I'd not usually do this. I use most of the times I use 1.5 for my first choice. But in this case, I prefer to use a smaller size to see how it goes. And I went the rate up, and it passed. And after that, I could deliver the balloons, and everything was fine.
one comment is like when in my practice, when especially dealing with heavily calcified lesion in the bigger arteries, if given a choice, I will always prefer orbital atherectomy for the reason I can nicely work in the lesion. I sometimes work with both the speed 80 and 120K. That will probably give me a better shaving off the calcium, better lumen gain, and that will help me in easy cracking of the lesion. Because otherwise, in rotational atherectomy in rota, we can just modify the plaque. You cannot shave off significant. You need to work. Initially, we have to work at high speed, then we have to work at 120 or 130 to get kind of similar shaving of calcium, which most of us may not be comfortable. So in that case, orbital atherectomy will help us to nicely shave off the calcium, shave major part of the calcified plaque, and then helps us easy cracking of lesion even in a bigger sized arteries.
Another thing is, your wire was actually not distally wired. It was just at the branch. So recently I attended one of the Rota Master. We mentioned about that from Japanese. He mentioned those kind of wiring. That means wire which is not very distal, which is very much near to your burr. Your rota tend to make this kind of orbital movements, some kind of orbital movements. So of course it's not very safe, but it has a better shaving chances. kind of minimal orbital movement. So that's something that we can take from here. Another thing is how comfortable are you using a rotor after multiple granuloplasties? That's also another arguments. I recently had a similar case. I had a 3 granuloplasties. The balloon just refused to go in. I did rotor after the granuloplasty in a circumflex vessel. And in fact, I presented, there was a few questions as how comfortable are you using rotor after granuloplasty, because some dissection may happen and all that. Of course, I think it goes back to your comfort level of using a arterectomy. And obviously, in this case, I don't think you have much choices. You really need to get the, you need to shave it off, because if not, your balloon cannot go in. Anything, any suggestions from your side?
Yeah, first of all, about the wire, I know it wasn't in the best place to be in the branch, but I tried a lot to drive it distal, but I couldn't in that moment. So I decided, as I was there, it was not that small, it was not a very small branch. So I tried to reach the rota bare till the proximal part of the wire, as we should do all, and there was no problem. The other question, no, when the balloon cannot pass, it's really, and you modify. I think the point is to do a little modification in the proximal part of the lesion. That's why I tried to use the small profile balloon, and although it burst, and they did a micro dissection, micro dissection. I was really confident. It's there is an issue using a rota wire after that, but rota bare after that, rota ablation. But I've done so many cases that in so many cases I had no a big issue with that. So I felt confident to use a rota ablation after that, and there was no problem with this.
So I think, I mean, it all depends on how comfortable are you doing your case, and the available tools that you have in your lab for you to do a case. So I think a very good case. So I think I will just
I will try to do the orbital atherectomy, because I'm not that familiar with it. I've done some cases, but not that much. So rota ablation is really a very good tool, and when you have done many cases, as most of us, you know when to stop, I think.
So okay, I think we'll move on. I'll be presenting the last case. So okay, so I'll be presenting two cases, not as complex as what Dr. Ioannis did. So, case number one, I have with me a 65 years old gentleman, diabetes, hypertension, lipid, and he actually had a coros done previously, 3VD with subtotal occlusion of the LAD early this year. EF was 43%. He was referred for CABG. So he was actually admitted in March 2023 with non-STEMI. He was counseled for CABG again. He was not keen, so he explored PCR options. So we brought him into the lab, and you can see this is the right side, the left side angiographic. So there's a subtotal occlusion in proximal LAD, calcified stenosis in left cert, and RCA was diffuse mid to distal RCA. So we actually wired the wired the lesion. All right. Okay. So And we actually pre-dilated the mid to distal LAD with a 2.5 scoring and also 2.5 at proximal LAD. So this was what we got after we pre-dilated. So we saw there's a diffuse disease LAD, mid LAD, there's bridging. We probably have dissected the mid LAD, and there is a poor distal runoff. So the next step was I was a bit concerned to actually stand it, so we actually proceeded with IVUS. So this is what we got in the IVUS. If you can see on your right side, this is the IVUS run. So distally, it was a very small vessel, 2.0, with a long segment of myocardial bridging around 30 mm. There was disease in a bridge segment as well. So medial, there was dissection, and proximal, there was a fibrocalcified disease of 360 calcium. So he did not actually fulfill the calcium score for calcium modifying with arterectomy. So we proceeded with NC balloon. So we actually used the scoring NC balloon which available. So we went with a wedge 3015, and you can see that it just opened up from the proximal LAD until the ostium. And we actually decided to DCB the distal with a 22530 and the mid LAD with 2.5 DCB. And after the DCB, we noted that there was a bit of dissection in the mid to distal LAD, but it's non-flow limiting. So we just stented the proximal LAD with 2.75 times 33 DAS from ostia to mid LAD, and we managed to stent just proximal to the bridging, and we post-dilated with a 3.0 high pressure and 3.5 proximally high pressure. So this was the final result of the left system. I mean, it wasn't that great, but with the bridging and what, so we thought that probably we would have stopped here. And this is the spider view and the cranial view. So there was no flow limiting dissection, and so we just ended our procedure on the LAD. So result was accepted, and actually patient was well, so we actually proceeded with the left side, and it was a bit dramatic, so we had to rotablate and then IVL. But I'm just going, I'm just showing the procedure done in the LAD. So we actually brought him back 2 months later because we wanted to stage the RCA. So this was the result that we had after 2 months of the procedure. You can see there was positive remodeling at the distal LAD, and everything was good. So we were happy. So we proceeded with the PCI to the RCA. So this is a second case. I have a 76 years old Chinese female, diabetes, hypertension, dyslipidemia, IHD, had history of non-STEMI 2018, but was not keen for intervention. So she presented to a hospital with a typical chest pain in a spoke hospital, which was 30 km away. And she presented with anterolateral MI. So they referred to us for primary PCI. So this was the diagnostic angiogram. You can see that there is a probably subtotal lesion at the LAD, mid LAD. Angiographically, you can see it's very calcified. And this was the right side. Couldn't really appreciate much collateral to the left system. So we proceeded with primary PCI to LAD. So we were having a little bit difficulty while wiring it, so we need to change to fielded XDR with a microcatheter. So we managed to cross with XDR, and we changed the wire to soft wire again. So you can see that the flow is still very diminished at the LAD. And we pre-dilated with Ray 2O, can appreciate that the balloon did not expand well. So we actually decided to for imaging to decide whether we need to modify it with a rotablator. However, upon opening the IVUS, patient actually became very hypotensive, very uncooperative. So we had no option but to quickly sort out the lesion. So decided to go in with a wedge scoring balloon 2.5 times 18 at 10 atmosphere. And then we went further up and we increased the size to 3.0, and you can see that the vessel actually opens up very well with our Wedge NC Scoring. So this was the picture after NC. So we were quite happy with the result. So we decided to standard it. So we stand it with a 3.0 times 38, and then upsize. This was the picture after we actually stented, and you can notice that there is bridging over the mid LAD. So we post dilated with 3.5 high pressure, and this was the final result. So since we already had the IVUS open up and not used, so we decided that we wanted to go in and have a look whether the stent were well opposed or not. So this is the caudal view. So when you can see that from the IVUS view that the MAA was good, proximal, mid and distal LAD was very good with very good stand opposition. So we accepted this result, and for scoring lesion, we think that for this scoring balloon, it's good for lesion preparation for stent, calcified and fibrotic lesion, osteal lesion, bifurcation lesion, long diffuse lesion, and small lesion without need of stenting, especially in our patient who we plan for DCB. So the balloons that I use for the case are all Wedge NC balloon, which they has previously it was SC, so they improved the performance by changing it to NC. Right. So I think with that, thank you very much.
Yeah,
So
thank you.
any comments, or anyone would have done differently or not?
No, indeed. I think the second case, STEMI, the presentation was quite complex. Like this heavily calcified in the background of STEMI, all of us will face difficulty in pushing any sort of device. So yeah, the initial strategy was good to see if there is any need for rotational atherectomy, because there was no visible thrombus. Obviously, even we do the same thing. But yeah, since the patient destabilized, I think that was the best call you took. We just took with the regular like a Wedge NC, pre-dilated it aggressively, so that whatever you can crack, you did that. And then finally, result was excellent. I think no one else would have done something better than this.
I mean, in MI, you're not expecting perfection. As long as you can achieve an acceptable luminal gain, I think it's fine enough to stop the procedure. I mean, sometimes you just push your limit, putting a 4.0, just want to get a perfect result, and then you end up getting complications. I think you should know when to stop. And I think you did just enough. You, of course, you even confirm with your luminal gain MLA by IVUS. I don't think we would have done anything different.
Yeah, me too. I think in the first case was a wise decision you made to leave the distal part and sit afterwards in a follow-up, because many times even in the CTOs or in occluded, even it's acute occluded or acutely occluded or chronically occluded the vessels, when we open the artery, we create a big hematoma the vessel, and we try to have the best angiographic outcome for the first. Maybe we create a problem and not solving the problem, and we have to leave the vessel to absorb the spot, to absorb the hematoma, leave and check it after some weeks and see that it's better, because when we put a stent and there's a big hematoma in the vessel, then we're not sure about the distal flow. And this was very wise from you, and I will do the same.
Daniel, there's a question for you.
What's the question?
The meeting chat.
I think there are a few questions. The first question is compared to other scoring balloons, is it better to use scoring balloon with one scoring element or three? So I think the first, the most important thing is what is available in your lab, what is available. So that will be the one. So if you have option, then probably I mean, in my opinion, I would probably say the one will be easier, because for us, whatever it is, deliverability will be our main concern. So if you have three, it will be a bit more bulky, but if I were given the choice, I would definitely choose a balloon that is more deliverability, that which definitely is the with a single with the one with one scoring element. Any comment from the panelists or from the speakers?
So obviously the 3-1 comes with higher cost as well, if you see, and it comes in a semi-compliant balloon. So the disadvantage there is like it is more bulkier since it has 2 or 3 wires, and then it is on semi-compliant where you cannot go, if the lesion doesn't crack, you cannot go at high pressure, and again obviously more cost. So compared to that, this wedge it is mounted on non-compliant balloon where you can go to very high pressure as well without dog boning or without bigger dissection on the vessel. And again, the strategy is in case of 3 wires, it scores at 3 different level. So the wedge balloon, what we can do is inflate at one angle, again rotate the balloon at different angle, again rotate some 3 to 4 rotation, probably will give the similar result what a 3-wire scoring balloon can do. And again, in this era where reimbursement is bigger issue, now the insurance company do not want to, they're a little bit stingy to give us any sort of this thing. So we need to customize, we need to plan, and then go with that thing. And again, crossability, the advantage of wedge balloon is, though it is mounted on non-compliant compared to other normally non-compliant balloons are bulky balloon compared to semi-compliant, which can cross any angles. But wedge, I have not had any bigger issue. And we also have a smaller length, like 8 millimeter and all, 6 millimeter scoring balloons, where in case if find, especially what happens is balloon, non-compliant balloon, if we take to 15 or 20 millimeter, and if there is an angulated calcium, if we need to cross it, the bulky balloon will not cross. In that case, I think what we have to do is we have to select the small length. So because these are mounted in non-compliant, the small length can easily negotiate the bend, and then we can position it appropriately and crack, and then that can do the needful for us.
Sometimes you can even use the cheap way method of multi-scoring by putting another wire. Of course, it also helps in delivering your balloon, but how success it is, whether it acts in a different angle, nobody knows. It just your own. But of course, better than one scoring. But most of the time, single scoring will do its job. And rarely the cases that it doesn't do its job are the cases that you deal with a major calcium where probably you need some kind of artery in those kind of devices. But most of the cases, single element scoring should do its job.
Yeah, I agree as well, because I usually use one scoring balloon. I don't do escalation in scoring balloon sizes, and after the medium scoring balloon that can be delivered, it's not that bulky. I do escalation in NC balloon in a bigger size, and as there's been a cracking in the calcium, this strategy I think works. And if it not work, then you have, I think, we have to use lithotripsy or something else.
So to answer this question, I think we all agree that one scoring element will be the best option if it's available lah. So as we have seen with what all of us have done with Wedge just now, which is a one scoring element balloon. So we have another question: how can you control the placement of scoring element? Probably Dr. Naveed, you demonstrated nicely with your case of control dissection. Do you want to, we probably can get your expert opinion on this. How can you control the placement of scoring element?
So normally if the lesion is long, I choose like 10 or 15 millimeter. If the lesion is very short, I choose a smaller length balloon. I make sure I position this balloon at the tightest spot and then go high pressure, because if there is rarely, because these balloons do not melon seed to the extent what the non-compliant or regular semi-compliant balloon melon seed. They slip. But this, because there's the other wire acts as like anchoring thing to the lesion, they don't slip or melon seed. So I position them at the tight spot, try to go slowly, and then once I feel the lesion, it is sitting in the lesion, I go high till I crack it, and then again rotate and crack at different angles. And I do not go much beyond the lesion, so I don't want the dissection, so I can limit my dissection within the lesion spot only.
Question is, Dr. Naveed, how, does rotation works? I feel like rotation doesn't really work, because sometimes he just takes his own bias, wire bias, and then, rotation is something, there's no rotation element there. Sometimes, maybe it's a minimal, I don't know, but I don't really use the rotational thing. Whether we can confirm it by IVUS or OCT, whether rotation works or not, I'm not so sure.
I have done IVUS in a couple of cases where I could see a different level. What normally I do is, once I score it, then I try to rotate the hub. I give like 360-degree kind of thing, and I rotate multiple. Finally, when I pull out the balloon, I see the wire is not straight anymore. It is little spiral. If you can check it, if you do it within the lesion, rotate, and finally when you pull out the balloon, if you see the wire on the balloon will not be straight, it will be at an angle. So that shows it moves within the lesion, and you will end up scoring at different levels.
It was a very nice comment about rotating. I usually don't rotate the scoring balloon, but after what we discussed today, maybe I'll start rotating.
Okay.
Yeah.
So I think there's no more question from the floor. I think we have seen a lot of cases. I've learned a lot from all of you today. From rotablator, from CTO, from very heavily calcified lesion, and we've learned and seen how we have shared the experience of how a scoring balloon actually helps us when we encounter this type of situation. So I think with that, any final words from any of the speaker?
I'll just start first. I think even I learned a lot. I've been relying so much on atherectomy before this, and of course, coming to this this presentation, I'll be using more wedge just to show, try to get more cases of wedge, and I find that we are just afraid of using all the newer balloons. We are so much reliant on all these devices, atherectomies. I think we can make it simple. I think the technologies is going to get better. Balloons just going to get better, and it's just going to make our life much easier. And Wedge NC has shown open a path where you can treat multiple lesions from severe calcium to ISR to preparing for DCBs in this single balloon. I think there are a lot of bigger things can happen with this with the new devices, and it's just going to get better.
So my final take is like know your tools, prepare for the procedure. So don't jump for higher tools. When you know when to use them appropriately, create your own protocol which will fit to your practice and the insurance. So then by knowing these tools, when to use them appropriately, you can minimize the cost without compromising patient's care and having good similar long-term results despite of using this like wedge balloon, which is obviously much lesser cost compared to cutting balloon or atherectomy or IVL and getting the similar results. So that's what I would advise.
And my final comment is that every time I participate in a meeting or a webinar like that, I understand that every step in every case that we do in our cath lab has for every step you have to take care all of these things. You have to be prepared for everything. You have to have the knowledge of the material used very well. You have to choose exactly what it fits every time. And when you're speaking with experienced colleagues and operators, you find the points that you have in your mind, and you see that everyone comes to that, and then you have to getting better every time that you're getting closer to other participants and to other colleagues. And this is the meaning of these webinars and these meetings, because we all talking about our experience, but when we put our experiences together, it's been multiplied. And for the people in the audience and for us as well, it's been amazing to getting better even with this procedure and getting knowledge from each other. So as for these scoring balloons, I think with the complete revascularization that we have achieved in our cath labs, it's nevertheless a weapon that we should have in everyday practice, and it seems that can do the job without so much expensive tools. And this is a point we have to have in mind. I was amazed with the demonstration of minimal dissection and the drug-eluting balloon after that, and I will try to do it in some of my next cases.
So we can conclude today that I mean probably we have overused the atherectomy. So probably with the new version of scoring balloon, we probably can try and see, because I think now the only issue will be deliverability lah. So if you can deliver a scoring balloon down, you can prepare the lesion well, then I think we can just we can prepare the lesion, then we can just get off with a scoring balloon. So I think with that, I end this very fruitful session. Thank you, everyone. Thank you, all the speakers, and all right, thank you.
Thank you.
Bye. Thank you all.
Okay. All
Everyone.
right, see you.